Hi, good morning everyone. My name is Lina from one of the acute hospitals in Singapore. Thank you for being here for the Journal Club presentation today. In this presentation, I will present one systematic review study conducted by Santos Marques from Portugal. The article was published in 2021. The article is titled Infection Prevention and Control Strategies Against Carbapenem-Resistant Enterobacteriosis, a systematic review. Overview of carbapenem-resistant Enterobacteriosis. The term CRE is used throughout the presentation. Carbapenem are broad-spectrum antibiotics and are used for treating multiple drug-resistant organisms. CRE is defined by resistance to at least one carbapenem antibiotics. It's a national and international concern that CRE develop resistance to these strong antibiotics by certain mechanisms. CRE is transmitted by direct or indirect contact by contaminated surface. Let's delve in the risk factor and the signs and symptoms of CREs. Patients in healthcare settings are at most risk for getting CRE, especially for patients who has underlying medical conditions, prior antibiotics exposure, prior hospitalization exposure, patient having invasive device, and having extended stay in the intensive care unit. There are no symptoms for CRE colonizers. However, for CRE infection, there are pneumonias, bloodstream infection, urinary tract infection, and wound infections. Why is management of CRE crucial? CRE has a few antibiotics treatment choice and a very high degree of antimicrobial resistance, both national and international concern for healthcare associated infection. Once infected with CRE, patient will have very high morbidity and a very high mortality rate. In order to prevent and control CRE, it's essential to establish a functional and effective IPC program at both the national and acute healthcare facility level. In 2016, the World Health Organization published guidelines that outline the fundamental components, which include education and training, surveillance, monitoring, auditing, and feedback. How this study is relevant to my area of practice. Although we're implementing IPC measures to reduce CRE spread, there's a growing concern about the rise in hospital-acquired CPCRE infection in my hospital in 2024. As an IPC nurse investigating the epidemiology of CPCRE and identifying the associated risk factor in the hospitalization patient of utmost importance. In Singapore, the acquired rate of CPCRE infection varied from 0.09 to 0.37 per 10,000 patient days from 2019 to 2021 during the COVID-19 period. To prevent CRE transmission, IPC strategies is equally important to antimicrobial resistant control, for example, antimicrobial stewardship. IPC measures are evidence-based approaches. Let's review the background of the systematic review. AMR is a growing global challenge. There are IPC guidelines including hand hygiene, transmission-based precaution, standard precaution, wearing personal protective equipment, environmental and equipment cleanliness. IPC measures are evidence-based approaches. However, there is no definitive IPC strategies for controlling CRE transmission. The study is helping us to understand which are the most adequate IPC measures. What is the research question for the articles? The research question is, what are the most effective and efficient strategies to prevent and control infection or colonization caused by CRE? Why this research question is important? Firstly, is to identify collect and evaluate the available evidence regarding the impact of IPC measures on CRE. Secondly, to evaluate the individual impact to each IPC intervention in controlling HAI and AMR dissemination. Thirdly, choose the most practical and evidence-based measures. The method of study is a systematic review. The literature search follows the protocol from systematic review and the meta-analysis guideline. Data search was conducted in July 2020 from the database Scopus, PubMed, Web of Science. Inclusive criteria for the literature search is a study must be published in English and between 1st January 2017 to 30th June 2020. Such terms use a combination of keywords in titles and abstracts. Exclusion criteria are the articles are not related to health science, studies including animals, non-research articles, study about genetic technology and pharmacological development. For selected article, risk of bias was assessed. For randomized studies, Cochrane collaboration tools are used to assess low, high, and unclear risk. For studies developed research, outbreak report, and intervention study of nosocomial infection statement are used. For case report, they are used case report checklists to assess the risk of bias. For the studies belong to cohort and the cross-sectional study, National Heart, Lung, and Blood Institute study quality assessment tools are used to assess the risk of biasness. Overall, 11,635 records were identified. 4,044 records are screened by titles and abstract. 3,892 articles were excluded. Among 152 full articles, 109 duplicate records were removed. 13 articles were excluded as not demonstrate IPC strategies. 30 articles was eligible articles are selected. Among the 30 articles, 1 is a retrospective and a prospective case control study. 3 are prospective study. 26 are retrospective conducted in the context of outbreak. Out of 30 articles, 19 articles are mentioned use standard precaution, transmission-based precaution to control CRE. Hand hygiene was mentioned in 63% of the articles to block the transmission of CRE. For recommendation to manage CRE, it's crucial to implement standard and transmission-based precaution as recommended by WHO. It should be tailored to the level of care to be provided to all healthcare settings. Hand hygiene compliance should be monitored and feedback to the frontline staff and communicate to the administration level. 24 of the study reported reinforcement of cleaning protocols is successfully in managed CRE outbreak. Recommended disinfectant should be used, for example, hydrogen peroxide vapor, hypochlorite and chlorine solution, UVC system. In 4 studies, environmental sample performed on healthcare workers' hands and gowns 20 points within 2 meters from the patient's bed, such as patient's bed, bedroll, cobble, bathroom, sink, toilet seat, wheelchairs, all are contaminated. So the recommended practice will be environmental cleanliness. Should be increased cleaning frequency at least twice per day for CRE patients with recommended disinfectant. Secondly, environmental and equipment cleanliness should be monitored using active surveillance culture. For cohort and isolation, in 24 studies, isolation or cohorting of CRE patients dramatically decreased CRE acquisition. 19 studies mention contact measures as evidenced by WHO guidelines to manage CRE spread. 10 studies mention protective equipment by healthcare workers use glove, gown, or apron for direct care or activities in the patient room, also control the CRE spread. So that's why the recommendation is isolation patient in the single room or cohort all positive CRE patient in the same room. Secondly, practice contact precaution in care of a CRE patient with gown and gloves. For educational session, there are 18 studies reported to conduct educational session on IPC principles, antimicrobial stewardship, contact precaution, hand hygiene, cleaning protocols to all the healthcare worker, patient, and family members. So the recommendation will be regular IPC training session to all the healthcare workers, IPC knowledge sharing to the patient and the caregivers. Next, I will share with you about the limitation of systematic reviews. Among all the 30 selected articles, most studies conducted in ICU as the patients there are highly vulnerable to MDRO. There are some studies have small sample size, single center study, small number of environmental samples, and the information on antimicrobial consumption is limited to the facility records. Lastly, the role of the patient and caregiver in IPC measures compliance and the influence on education and the training are not mentioned. Validity use critical appraisal skill program. CASP. CASP checklist for system review with meta-analysis for studies is used. So this study addressed clear the research questions. And the research is a methodology sound for literature search and assessment of the risk of bias. The results are truthworthy as followed by WHO guideline. The last, the results are relevant locally and can be adopted in the local context. In conclusion, this systematic review highlighted the importance of IPC strategies to contain CRE spread, evaluated the individual impact of each IPC interventions. The evidence-based IPC strategies discussed in the studies can be applied to other outbreaks or local healthcare settings. It also chooses the best practical and evidence-based measures. The following IPC strategies in the control of CRE dissemination, it will be benefit to apply in our local hospital setting to practice standard and transmission-based precaution with good hand hygiene, to give real-time feedback to all the healthcare workers, to communicate to all these higher administration level about the compliance rate, to maintain environmental and equipment cleanliness with very close monitoring and feedback the compliance rate to all the stakeholders, to isolate every CPCRE patient in the single room, or cohort every positive CRE in the same room. Lastly, to conduct training and education to all the healthcare workers, patients, and the caregivers. Thank you everyone for listening.